you might think that there is something going on in this region here, but it's not very clear. However, if you take stress views, such as the ulnar deviation view, there might be more evidence of the fracture coming into view in this particular X-ray. And in this here X-ray here, you can then see the fracture line. Yeah. So what should we do when you are presented with this kind of a clinical scenario? So you would like to investigate further, and the usual investigations are of computed tomography, an MRI scan, or a bone scan. So CT scan is the usual recommendation for acute fracture of the scaphoid or subacute fractures when the fracture line is seen on the X-rays and you want to investigate further. However, if there is a bony bruise and you cannot see the fracture on the X-ray, or it is an unequivocal kind of a presentation, then usually an MRI is recommended. We'll see that in the subsequent presentation. So the CT scan that was performed revealed that there was a widened scaphoid interval. There was a scaphoid non-union at around 2 or 3 months and a mild DC deformity with a proximal scaphoid density. And this is how the CT scan looks like. So you can see the fracture line very clearly here, as has been highlighted by the arrow. And then there is a slight increase in the density in the proximal pole of the scaphoid. And these are other sections where you can study the fracture anatomy in greater detail. So what are the treatment options at this juncture? You may think of a long arm cast. You may think of fixation with K-wires, or you may think of fixation with bone graft and K-wires, or the standard headless compression screw with or without bone graft. So we decided in this particular case, because it was a proximal pole fracture, to go ahead with open reduction internal fixation. You can see the fracture line here. You can see the bone graft that has been, the mossealized cancerous bone graft that has been packed into the non-union side. And then you put in a Herbert screw or headless compression screw, taking care that the screw is completely subchondral. And then you can see in the immediate intraoperative imaging that the screw is very well placed on the long axis of the scaphoid. So with that brief introduction to a very typical case scenario that you might see in clinical practice, let us now get into the details of scaphoid fractures, beginning with the anatomy. So we all know that 80% of the scaphoid is covered by articular cartilage, and there are multiple ligaments that are responsible for maintaining scaphoid or scaphoid unit stability, and the scaphoid is connected to the surrounding carpal bones via multiple ligament attachments, and the vascular supply of the scaphoid is very peculiar. And we should also appreciate that the scaphoid articulates with 5 bones: the proximal pole with the scaphoid fossa of the radius, the ulnar border of the concavity of the scaphoid articulates with the capitate, as you can see here. You have the distal tubercle, which articulates with the trapezium and the trapezoid, and then you also have the scaphoid unit articulation here. So the blood supply of the scaphoid is the next important concern or issue when we are talking about scaphoid anatomy and fractures. And to understand why a lot of scaphoid fractures will not fuse, it is important to understand why the blood supply of the scaphoid. It is a pretty precarious kind of a blood supply that the scaphoid has. So as you can see in this particular picture, the blood supply of the scaphoid was very well studied and described by studies from Richard Gelberman and his colleagues. And you can see that there are two main blood supply arteries, or arteries that uh, supply the scaphoid. You have the dorsal carpal branch and you have the superficial palmar branch. So the dorsal carpal branch enters via a narrow dorsal ridge along the waist of the scaphoid, right here. And this particular branch will perfuse about 70% of the scaphoid, including the proximal pole. So there are branches going all the way to the proximal pole as well. Whereas the superficial palmar branch enters through the distal tubercle, as you can see here, and perfuses about 30% of the scaphoid, including the tuberosity of the scaphoid. So again, if you look at this particular view, you have the dorsal carpal branch here, and then you have the superficial palmar branch, which enters through the distal tubercle of the scaphoid. This is a decalcified specimen of the scaphoid. And again, here you can see the different branches. This is the palmar branch, and this is the dorsal branch. And you can see this particular branch is responsible for supplying the proximal pole and much of the waste of the scaphoid, whereas the superficial palmar branch will supply mostly the distal pole. So having understood this, let us now proceed to understanding the biomechanics. So majority of fractures that involve the scaphoid are a result of a fall on an outstretched hand. And there is a hyperextension of the wrist in more than 95% of people who have a fall. And there were certain cadaver studies where they looked at the mechanism of injury, and they found that the waist of the scaphoid is where the fracture pattern or the fracture line is most commonly seen. It is usually seen in extreme dorsiflexion and ulnar deviation of the wrist joint, and this is when the scaphoid gets impinged on the dorsal limb of the rim of the radius. So this is something which is called as the nutcracker effect, and that results in scaphoid fractures. Location-wise, majority of fractures involve the scaphoid. As you can see in this particular schematic diagram, about 10% involve the distal pole of the scaphoid, and about 20% will involve the proximal pole of the scaphoid. There are several classifications for scaphoid fractures. You have the Mayo classification, which looks at the localization of the fracture, the Rusi classification, which looks at the fracture plane, and the Herbert and Fisher classification, which takes into consideration the stability of the fracture. So the Mayo classification, based on fracture location, classifies scaphoid fractures as those of the tuberosity, those of the distal articular surface, the distal third of the scaphoid, the waist and the middle third, and the proximal pole. So this is the Mayo classification. If you come to the Rusi classification, this takes into consideration the plane of the scaphoid fracture. This is pretty akin to fractures of the neck of the femur. So you have a horizontal oblique type, which is the HO, the transverse type, which is the T, and the vertical oblique, which is the VO. So the increasing obliquity of these fracture patterns or these fracture lines will be responsible for worse prognosis. And that is because of the risk of displacement of the fracture. So if you have a vertical fracture line such as this, and if there are forces that are acting on the scaphoid, it is but natural that there will be displacement and the distal pole or the distal fragment will flex, resulting in a DC deformity. The Herbert classification takes into account the stability of the fracture, and the classification talks about type A, B, C, and D. Type A is where the fracture line or the fracture pattern is stable. So if you have a fracture of the distal pole, for example, or the tuberosity of the scaphoid, and if it is a unicortical fracture, it is considered or deemed to be a stable fracture. An unstable fracture, or the B type, is any fracture where there is either a comminution, or if there is an obliquity of the fracture line, or if it involves a proximal pole, or if it is a part of a transcaphoid perilunate fracture dislocation pattern. So we are going to talk about the transcaphoid perilunate and carpal injuries as we go through this learning process. Type C is a delayed union, as you can see here, and there is usually some fibrous non-union in this particular area. So this is again kind of an unstable fracture pattern. And type D is an established non-union late presentation, where you can see either a fibrous non-union or you can see a pseudoarthrosis with a cyst formation. So this is the Herbert classification. Another classification was described by Bill Cooney from Mayo Clinic, where they further modified the fracture classification by identifying unstable injuries. So fractures with more than 1 millimeter of displacement, a lateral intrascaphoid angle of more than 35 degrees, a bone loss or comminution that may be associated if the fracture of the scaphoid is a part of a transcaphoid perilunate fracture dislocation or a greater injury pattern, if there is a DC alignment, a dorsal intercalated segmental instability pattern, or if there are fractures of the proximal pole of the scaphoid. These are the situations where you should consider open reduction internal fixation or a surgical intervention wherever such patterns exist. So what is the rationale for operative treatment? Why are we so finicky about scaphoid fractures? Why are we so aggressive about scaphoid fractures? And our thought in advising aggressive treatment comes from these figures out here. Scaphoid fractures are known to have a non-union rate of anywhere between 15 to 40%, a malunion rate of 10 to 30%, and a delayed healing even in casts that may be continued for about 6 months. So when you look at these figures, it is easy to understand why we tend to advise surgery to our patients when they present with fractures of the scaphoid. However, we need to identify and understand exactly what those indications for surgery are, and we will do that as we go through this particular talk. So the scaphoid is a very peculiar bone with a large articular surface, and it has a greater risk of non-union because there is no external callus that forms which can stabilize the bone. And the purpose of the implants that we use is to stabilize the fracture site to prevent shear forces that will disrupt the internal healing process. And that is the reason why we use these headless compression screws or K-wires at times to fix these fractures. So when you are presented with acute scaphoid fractures, there is a certain role of a limited open reduction and internal fixation, and the indications of these fractures are when they are minimally displaced and you want to achieve